Okay, welcome everybody. Today we're going to be doing an online talk about discharge planning, specifically talking about the durable medical equipment and letters of medical necessity needs that your patients might need when discharging from your rehab services. So what are some of the things to consider with discharge planning? Some of the things that occur can be home accessibility and recommendations, addressing any durable medical equipment needs. Definitely, we have to plan and prepare patients and family members for going home. So, a lot of family support and training is needed. And a large part of your time, especially in the inpatient rehab setting, will be spent trying to figure out what will be the best equipment options for your patients and clients. But with discharge planning, this is something that you're involved with both in the inpatient arena as well as in any outpatient facilities. You're still going to be working on family training and equipment needs and addressing those needs. In both of those settings, the focus just might be a little different. The main focus is for inpatient settings. If they've been living at the hospital during this time of care, you have to get them ready for going home. And so obviously the plan is hopefully discharge to home and doing everything that's needed to get them there. If you're seeing them and treating them in the outpatient or day program arena, then most likely they are already at home. But you will still definitely be planning for discharge. We will be addressing any equipment needs and family training needs. And in both those settings, inpatient and outpatient, you're always going to be involved in planning for the continuum of care. We've said this before, but within the inpatient arena, oftentimes they are going to continue with therapy, whether that's going to be in a day program or outpatient or home health basis. When they leave your outpatient services, it might be that they are discharged from physical therapy care for a certain period of time, and then the plan is that you will check in with them in 3 to 6 months if we think they still might have goals, or they might have met all goals and they're free to go, good to go. So a lot of times in some of the documentation I receive when doing the practical exams or even with the mock clinic, some of you wrote that you were going to discharge to home, which if they're already living at home, they're already there. So yes, there's always going to be discharge planning. It's just the focus will be different. I also apologize. I'm recording this from home. I have the yard guy out front and a dog that will most definitely bark at the yard guy and soon to be male person coming by. So I apologize for that. So let's move forward. So this is a video clip I'm going to show very quickly. And this is a spinal cord injury patient that I ran into when going to MedTrade a couple years ago. MedTrade is an annual DME conference that comes to different cities throughout the country, and occasionally we'll come to Atlanta. And I ran into this patient who was there with a friend of mine who was a PT who had her therapy team there. And it was a great opportunity for the patients to explore all the durable medical equipment options that are available and try out some things. So be on the lookout for this if you have a MedTrade coming to where you will be, because this could be a great therapeutic outing to do with your patient team. Okay, so why were you here today?
We're here with our PT and OT.
Hi.
To see what type of devices are out there to help us when we're looking at living independently.
Yeah, specifically you said bathroom equipment?
Yes, I'm showering on my own, but I need I need assistive devices like handrails, bench, things like that.
Okay.
So that's what we were focusing on.
Okay. Get any good ideas?
Yeah, there are some good ideas. We had some suction cup handles that would work, but they don't support the full body weight. So, I think I'm still going to need to look at putting in something more permanent.
Like a handrail? Yeah. Where are you from?
I'm from North Carolina, from eastern North Carolina.
Okay. How'd you end up here at MedTrade?
Oh, this was an outing through the Shepherd Center.
Yes.
So I never would have heard of MedTrade.
All right. Well, thanks.
Sure thing.
Okay, so he agreed to be interviewed, and He was interested to see what he could learn on this therapy outing. So, especially in the inpatient arena, we are going to be dealing with a plethora of DME or equipment options that we need to help and guide the patient to choose the best option. So, we're going to be examining and exploring the appropriate wheeled mobility device or wheelchair, as well as wheelchair cushions. We're going to try to recommend the most appropriate bathroom equipment. We might need to recommend appropriate hospital beds and or mattresses, transfer devices, and assistive devices and bracing. And this does not include adaptive equipment or assistive technology in the inpatient arena that usually falls in the OT's hands. And at Shepherd, the way the PTs function, we are in charge of recommending all of this equipment that you see here. All right, so just a review. I know we talked about this way back in first year, very briefly in the PT Interventions 1 class, but we are going to be working with our patients to try to figure out, A, if they're going to need a wheel mobility device for the long term. And if maybe not for the long term, they might be able to just rent something for a short period of time. And if they are going to need a wheelchair, we're going to try to figure out if they require a manual wheelchair, a power wheelchair. Sometimes they might need both. We can talk about that further. But so we're going to try to figure out if they are in need of a rigid wheelchair, which is more appropriate for patients that don't have good functional lower extremity use, or a folding wheelchair, which is an ideal type of situation if someone has good lower extremity use, but they might not have the endurance for full-time ambulation. Or they might even need a backup manual chair or a dependent chair. Transfer chairs, they are manual chairs, but they have very small wheels, and they're used primarily just to get a patient from point A to B for caregivers. Or we might be looking into power wheel mobility devices and trying to figure out what wheelchair base is going to be best, whether front wheel drive, a rear wheel drive, or a mid wheel drive. And if they need a tilt recline mechanism or a no tilt recline mechanism. So those are just the chairs itself. We also are going to try to figure out how they are going to propel these different devices and what different drive mechanisms. When we go to the Shepherd lab, you are going to get a chance to, if you would like, to drive all the different types of power wheelchairs and play around with the different type of drive mechanisms, to include the head control, the sip and puff, hand drive. Those are probably the three most common. So you'll get a better feel and understanding for the different mechanisms too, and for whose those are going to be appropriate or not. Always remember that for Medicare to pay for a wheelchair, it has to be considered medically required, and that it must be required for ADLs in the home. So a lot of times a wheelchair company, so this is that hierarchy of mobility aids. So if a patient can use a cane or crutches, then to get around the home to be able to perform toileting, feeding, dressing, grooming, or bathing, then Medicare will pay for that. They're not going to pay for anything that goes beyond that. Okay, so this is kind of, in order to get Medicare to pay for a power wheelchair, they must need that in the home to perform those ADLs. So usually a wheelchair insurance company will pay for one wheelchair, and sometimes someone might require both. They might need a power wheelchair in the community for community navigation and access, but they also might still benefit from using a manual wheelchair, or they might be in that transition period of trying to get away from power and going to manual, or they might use a manual chair in the home, but then they like to use a power chair to be able to go long distances because they might have orthopedic issues like shoulder problems, elbow problems, and wrist problems. So sometimes we do have to try to figure out the best way to get wheel mobility devices covered. And if they're only going to have one, And if they really do need this power wheelchair for ADLs, then we're going to go for that because it is a lot more expensive than a manual chair. We might try to get a donation for a manual wheelchair or have them self-pay a manual wheelchair if that's going to be another option. So when we are in the inpatient arena environment, when it's time to pick a wheelchair, they will go to the seating clinic and see an assistive technology provider who will measure and prescribe the appropriate wheeled mobility device for the patient. And the inpatient therapist will give feedback to that seating specialist, which at Shepherd Center, the seating clinic, I think we have a couple PTs and a couple OTs that are in there. But we'll give the feedback about what type of vehicle that they have to be able to transport a chair. What is their home like? Do they have tight spaces? Do they need something like a mid-wheel drive because of that? So we will recommend the wheelchair and order it kind of maybe at the halfway point of the rehab stay because we want the process to be started so we can have a chair ready for them by discharge. And a lot of times the vendors, if it's a very specialized chair, they have to supply a loaner for a period of time until they get their permanent chair. So we will take them to seating clinic. They will be measured and fit, and they will be given a very extensive wheelchair prescription. And then we, as the primary PT, will be involved in justifying that wheelchair to the insurance company, which includes a very detailed letter of medical necessity for why they need that wheeled mobility device for their lives. Once they receive or they get notice of their permanent wheelchair, we ideally like for them to go back to the seating clinic, even if this is, hopefully they get it when they're in day program or outpatient and you're there to help them with this. But we really like for the vendor to bring it to the seating specialist so that the seating specialist can make sure that the chair is ordered as it should have been and that it fits the patient well in case they need any more. So we've already talked about posture and the importance of posture back in PT Interventions 1, but it's important to note that posture doesn't just impact skin integrity, but it can have an impact on respiration, swallowing, digestion, circulation, balance, your upper extremity range of motion, the ability to move outside your base of support, and obviously to skin integrity. We want patients to have as symmetrical sitting as possible with equal weight bearing and to be as erect as possible. So right now while you're listening to this, if you do me a favor, slump way down in your chair, slide your butt forward, and then try to take a deep breath. Even try to swallow or try to move your arms up above. Yeah. And then recognize how that is different than if you sit all the way back. Now your ischial tuberosities are firmly back. You've got a good lumbar curve. We don't have excessive thoracic kyphosis then. And now try to take a deep breath. And you'll see that you are able to take a much fuller breath. So posture has such a significant impact on everything. And it definitely has an impact on function. And it's why the seating goals and what we do in the seating clinic are so important. Okay, so when we think about our seating goals, they are numerous. It is to help to reduce risk of secondary complications, enhance respiration and swallowing, correct or accommodate a skeletal deformity, assure comfort and balance, promote a symmetrical and stable sitting posture. Because let's think about it. People that use wheelchairs will be sitting in these wheelchairs most likely for the whole day. We want to promote skincare, provide safe equipment and training to reduce mobility-related injuries, and also improve and increase functional independence. So good posture in terms of seating begins with the pelvis. And one thing to think about is, and what we're going to talk about in the next couple of slides, is talking about deformities that we see. Deformities can be flexible, That is, it's a change from the normal posture, or they can be fixed, in which case there's not that ability to change. The flexible deformity is correctable most of the time. And that's usually because the issue is due to a more acute injury. The intervention for a flexible deformity is to correct the deformity, and you can be aggressive in the intervention. In this gentleman on the left of the slide, he has a flexible deformity. If you look at him, he doesn't have 100% symmetrical sitting posture. On the right, this is an example of a pretty extreme fixed deformity. It's usually associated with more chronic conditions. With fixed deformities, they are stuck in the abnormal posture, and no matter how much force you apply, you cannot change it. In order to manage these deformities, you must accommodate the pelvic deformity. But you can see some of these really significant pelvic deformities and postural deformities in kids as they grow up. And you can only imagine the implications that this gentleman has because of this fixed deformity. There can be issues with respiration. There can be impact on bowel care. Might need a colostomy because everything is squished here and we don't have our normal trunk to have room for everything. Can have a significant impact on skin integrity. So even though they are now stuck in this position, they could continue to get worse, and so that is why accommodation is the posture goal. So goals for addressing posture impairments are to correct flexible deformities, accommodate non-flexible deformities, provide appropriate pelvic trunk support for function to allow the hand free balance and reach, and minimize effects of excess tone and spasticity, and ultimately to maximize comfort. So what they did, this is an example of correcting this deformity, and they were able to do this by adjusting his seating surface and basically making a cell of the wheelchair cushion higher on this side of his ischial tuberosity, and that was able to then adjust and bring his pelvis more level. So if I go back to the old picture, to this, that's before that correction of the flexible deformity, to now a more appropriate cushion, then we get an overall better symmetrical surface. He also has some lateral supports here too, and that's also helpful for someone that might have a lot of trunk weakness so that we can get good symmetrical seating. So how do you manage these deformities? First, you have to determine if the deformities are flexible or non-flexible. Sometimes they say this as fixed. The pelvic position is key. And once you do know if it's flexible or fixed, then you can configure the seating system to provide 3 points of control. You will determine whether it's flexible versus non-flexible by doing a mat evaluation. So the mat evaluation for the pelvis. The mat evaluation is done in the supine position. First, you start with looking at the pelvis. The ideal pelvic alignment is neutral to slight anterior tilt, level, and not rotated. So you will first look at the pelvic tilt or lumbar lordosis. Start supine, then bend hip and knees and feel for how much anterior post tilt the client has in the sagittal plane. That's this example up here. Recognize that sometimes you might have to have a second hand because especially if we have profound paralysis, you might need a second hand to help with being able to feel the pelvis and where the legs are. Then you look to see or feel if there's a pelvic rotation. You will find this by feeling that one ASIS is higher than the other, and this would be a deformity in the transverse plane. Okay. this is an example of a windswept deformity, but obviously in this picture, this left ASIS is higher than this right, so we have a pelvic rotation here. Then finally, you look to check for a pelvic obliquity. You do this by placing your fingers over the iliac crests on either side and feel if one is higher than the other. This is the picture of feeling where those iliac crests are in space. This is how you assess for a pelvic obliquity, and this would be a deformity in the frontal plane. Later I'm going to put some links on this for you to watch a full mat evaluation so you can see that. So when we talk about pelvic orientation, the pelvic obliquity is going to be named by the low side. So in this example, a right pelvic obliquity means that the right pelvis or the right iliac crest is lower than the left. Okay, so this right pelvis is lower than this left. So this is a right pelvic obliquity. Pelvic rotation is named by the side that the pelvic faces. So he doesn't have a pelvic rotation, but a left pelvic rotation means that the right ASIS is more anterior in the transverse plane. So I just think about if you have your hands on the iliac crests and you have your fingers on the ASISs, and if it's a left pelvic rotation, that means your right ASIS is more anterior than your left, and so the pelvis actually will then turn and face toward the left. We'll probably do some just making sure everyone's clear about this in class too. You would then name if you feel a pelvic anterior or posterior tilt, and then you also, if you can put them in a normal pelvic position, then we know that it's a flexible deformity. If you cannot budge them, then it is non-flexible. So this is an example of a right-sided pelvic obliquity that is flexible. The second example here, this is an example of a right pelvic obliquity that is fixed and a right pelvic rotation that is fixed. And you would actually be able to know this better if you were able to palpate it on the patient. So again, here, this is an example of well, you tell me, which one? You look at this and tell me which is the three that we see. Which picture is an example of a pelvic obliquity? Which one is a picture of an excessive posterior tilt? And which one is an example of a pelvic rotation? I'll give you a second to think about it, and then I will tell you the answers. So let's go to the easy one first. We can definitely see here, this is an example of an excessive posterior pelvic tilt. Obviously, we have some pretty significant skin issues as well as function issues, but especially this is where we might get some skin breakdown of the sacrum back here. B, this is an example of a pelvic obliquity, so it's a deformity in the frontal plane. We have this right iliac crest is higher than the left. Okay, so in this case, then, this is an example of a left pelvic obliquity because it's named by the lower side. The skin potential risk here, then, is going to be on the left side, ischial tuberosity. So you can imagine if you just lean over in your chair onto your left side because your pelvis is dropped down lower, you can feel more pressure there on that left ischial tuberosity. And then this would be an example of an excessive pelvic rotation. And a lot of times you know there's an excessive pelvic rotation because you'll see one leg is further out, the knee is further out than the other. Okay, so here we have the right ASIS when palpating would be more anterior than the left. So the pelvis is facing this direction. I wish I could flip my arrow around, but you get the idea. It's facing towards the patient's left. So this is a left pelvic rotation. Okay, got it? All right, we go to the trunk posture. Then we want, our ideal trunk posture will be midline spinal alignment, normal lumbar lordosis with maybe a little slight thoracic kyphosis. So during the mat evaluation, you will look at trunk posture both in supine and in sitting. And FYI, if the patient is very dependent, you might need a second hand to look at the sitting trunk posture. So now this is actually my old OT partner, but obviously this is taking the picture. She's laying down on the mat, so we're just looking down and just trying to show some examples of the changes in the spine that you might see. So we could see excessive lordosis in supine. So you would look at a lumbar space or excessive kyphosis. Can the client lie flat without pillows for supporting the head and keeping neck neutral? You're also going to look for a scoliosis or a lateral curvature of the spine. And a convex scoliosis is always named by the side that is convex. So usually if you see a convex scoliosis, like in this example, they've just put Sarah in this position here, but this would be a convex, this is the scoliosis here. When you have it on one side like this, usually one shoulder will be up higher. So that if you have an S-shaped curve, then the shoulders will balance out and they might be level. So it's named by the convex side, not the concave side. So this would be a right-sided scoliosis. You're going to look for rotation to see if you would feel the rotation by checking the top of the ribs or the shoulders, and also look to see if you see a rib hump in the rib area. Does any area of the rib cage seem more prominent than the other? Rib cage deformity resulting. So do you have a rib cage deformity resulting from rotation of the vertebra with scoliosis? So let's just clear that up too. Scoliosis named after the side that is convex. This is an example of a right thoracolumbar scoliosis, okay? And this is that little picture just to say, okay, this is the concave lens, convex lens, this is the concave lens. So this is the direction that curve is going towards the right. So this is why you name this a right thoracolumbar scoliosis. And this would be some other examples of an unequal gap between arms and trunk. One hip might be sticking out more. The head might not be centered over the body. One shoulder might be higher. One shoulder blade higher and possibly sticking out more. And you would see that spinal curvature. So this is what we would be looking for posteriorly. So just again to review how we have the scoliosis, the normal spine here, then we start having a curve here, and then we have a severe curve here. So severe and balance and changes. So how would you name this? What is the direction that the convex curve is doing? Well, you have to also get your orientation. Now we're not looking from front on, we're looking from the back. So this is the left side of the body, this is the right side of the body. So this is a left scoliosis. But it's also important to note, look what happens to the pelvis when this occurs too, okay? So this is why too, with this left-sided scoliosis here, thoracolumbar scoliosis, we're also going to be getting a pelvic obliquity, naming it by the low side, right? So this would also be a left pelvic obliquity. We don't know if it's fixed or flexible because that is determined by clinical evaluation. You can't really know that till you get your hands on the person. So let's try naming it then from the front view. If we look at this person looking front on, we have these ghost hands here just hanging out on the person's pelvis, and ghost hands down here and ghost arms, but you get the idea. Those are the clinicians that are holding onto the patient. So we have tilt to the left side obliquity here, okay? We can see a convex curve of the spine, okay? So this would be going towards the patient's left side with the left pelvis drop down. It's fixed, meaning if in this picture it's showing a fixed deformity that they're trying to correct it and they can't. But here it's a flexible deformity. They're able to correct that abnormal posture. But this would be then a left thoracolumbar scoliosis with a left pelvic obliquity. And there we go, and one more. This is obviously a very extreme person. This is on a different person. We can see some major changes within her trunk alignment. We have a pretty severe left scoliosis, left pelvic obliquity, but you can only just imagine the skin issues and the pressure changes. Where is there going to be potential for maceration? It is going to be right here. Where is going to be potential for increased pressure and changes? It's going to be under this greater trochanter. We could also then have, ischial tuberosity, but we also have pretty significant skin breakdown here on the left greater trochanter just with the positioning in the wheelchair. And you can only imagine the impact of infection that we have here.